that we have today. So without any further ado, can we move on then? Okay, right. So quick look at the agenda. We're focusing first of all on a very important case study, and then spending some time looking at that in groups. And then we'll have an update about what's happening, particularly around the strategy with the ICS. And then we've got Javed joining us with to update us on what's been happening as they've been setting the thing up, with hopefully plenty of time for Q&A, and then brief summary at the end and finish by 3 o'clock. So without any further ado, can we move on then to the case study? And I can just say welcome to Fiona Price, Emma Ruckle, and Catherine Kirkham, and I'll leave you to introduce yourselves. Fiona.
Thank you very much, William. Appreciate it. And good afternoon, everybody. I think it's just afternoon, isn't it? Yes, we've just made it through. So thank you very much. I'm just going to introduce myself. So I am Fiona Price. I am the Chief Executive of Age UK Berkshire, and I'm joined by 2 of my colleagues who've worked together with us on this project.
Hi there, my name is Cathy Kirkham. I'm a clinical project manager for BHFT, Berkshire West Community Health Services.
And hello, my name is Emma Ruckle. I am the Urgent Community Response Pathway and Integration Lead for Berkshire West, also working for Berkshire Healthcare.
Thank you. Stephen, if you could just move the slide on, that would be great. Thank you.
Oh, got some feedback there. Sorry, carry on, Fiona.
This project commenced in January this year. It was a pilot. Can you go back a slide, please? Okay. It was a pilot under the Ageing Well Winter Pressures funding, and it was a pilot for Reading and Wokingham. This was from the Urgent Community Response Service, which provides rapid assessment, diagnostics and treatment to people in their usual place of residence as an alternative to hospital admission. So this service was previously known as the Rapid Response and the Rapid Response and Treatment Team in care homes. And the service is suitable for people who experience a crisis and require intervention within 2 hours to prevent them going into hospital. Healthwatch Berkshire was asked to undertake a survey to ask individuals about their experience with the Urgent Community Response Service, as the service was relatively new, and we wanted to understand how it was feeling for our patients. Sorry, can you go back, please? They provided qualitative data rather than the normal process of quantitative data. Next slide, please. The service then was unbiased because it was held up by an independent third party, as in Healthwatch, and it allowed the service users to share their experiences freely without any concern about their future care. The project was set up as a direct response to the Healthwatch survey recommendations, as it was identified that the UCR teams were not utilising the voluntary sector resources due to the lack of understanding of what was available and the complexity in how to access the systems. The project was named Keeping in Touch, and following a successful pilot project, it's extended and funded by Wokingham Local Authority for a further 12 months until March next year. Next slide.
So in terms of the project objectives, initially it was about identifying who was appropriate to be moved onto the pathway. And these were individuals who could be at risk of requiring emergency health or social care interventions. It was ultimately about providing an extension of a pathway. So once they were leaving their health intervention, it was about embedding and preemptive what support these individuals could require in the future, giving them tools, mitigations to raise their resilience, to try and prevent them ending up back at a point of crisis, or certainly give them the tools to be able to identify when to seek support sooner. It provided a single point of access for the teams but then opened up a range of other signposting opportunities to other voluntary sector organisations. It was about involving carers and relatives in that forward planning process. Also a big focus on well-being of both individuals who had been referred and their carers. And finally, about identifying and intervening in wider determinants of health, for example, supporting social isolation, housing, transport and other areas. Next slide, please. And so the pathway was set up that referrals or individuals who are appropriate would be identified by the urgent community response team, and consent would be sought for them to be referred onto this pathway. That was then broadened into a wider areas, including intermediate care could also refer into this. Age UK Berkshire then would review and triage those referrals, carry out a welfare kind of checklist that had been put together, and then would follow up on that. And the follow-ups were really determined by the needs of the individual. That could be one-to-ones, it could be supporting people access services, so kind of joint visits. It might be simply telephone contact and onward referral and signposting, but it was really built around what the needs of that individual. And then finally, making sure that outcomes, the activity delivered on the pilot was documented so we could get a good understanding of what interventions had been done and how the pilot had worked. Next slide, please.
So this is just to give you an idea of the number of referrals that we received over the month. So you'll see in the pilot period, we received 20 referrals, and then we had various months where we saw up and down. So in total, we had around 50 people referred in the first half of the year. And then we also then found that what happened was that a lot of people were being referred directly for the Keeping in Touch project. But because of the close relationship we then had with our NHS colleagues, they were getting to know more about the work that we were doing to help and support people in the area. And they were referring to other services directly as well. So we supported 83 people until the end of August. Thanks. Next slide. So obviously, as we are in Age UK, so we are supporting predominantly older people, but we were very clear that what we didn't want to happen was for anybody to be excluded from this valuable project. So as you will see, we did support a variety of age ranges, obviously predominantly due to the nature of the referrals coming through from the health teams and the nature of the calls to them. It was predominantly from that 70+ age range, but we did support a wide variety of ages through the project. Thanks. And just to give you an idea in terms of onward referrals, so we did obviously an awful lot of work through the project was about talking to these individuals about what their needs were. The nature of the Keeping in Touch project is to assess, triage, and then support for as long as needed, as Kathy said. And there were a number of different areas that clearly came to the fore. So this is the top 10 that came to the fore throughout the project. The main one was around specialist information and advice from our team. A lot of those individuals were people who were beginning to worry, understandably, about the cost of living, worried about paying for care, worried about getting through the summer and what was coming in the winter as well. We had a lot of calls around and support around cleaning, other identified specialist information advice, particularly around debt, and then some really practical help and support as well. So carers, OT assessments, befriending, and we work closely with our friends at Link Visiting Scheme, our handy person service and transport. So the really interesting thing for us was in total, there was at least 4 areas for each individual that we supported. So they weren't just coming to us with one issue, there was lots of other areas that we could help and support with as well. Thanks very much. So just to give you an idea in terms of some of the additional things that we find was the process of consent was incredibly important, because what we found that on our first contact with some of these individuals, they were really keen and fully briefed on what we could do to support them through the Keeping in Touch project. And we only had 2 individuals who felt that they didn't need any help at that time. We made close to 400 contacts, as you'll see, and the average length of support was around 7 contacts. So you can imagine that we were getting some quite complex individuals coming through. We still continue to support a lot of those individuals. We've still got 19 individuals who are on the programme from the August period, and we're continuing to receive more referrals. One individual we worked with in particular, we realised there was definitely a safeguarding need, and we worked closely with our colleagues in the NHS and with adult social care to make sure that that referral happened and they got the additional help and support that was needed. It also meant that we had a really good relationship with adult social care. So we managed to do some joint visits to really help and support people with some complex needs, particularly around hoarding, which was one of the things that really came to the fore with some of the referrals that we received. And what we were really pleased with was a couple of the individuals who were unfortunately admitted to hospital after we supported them. When we then came back to us under our Home from Hospital scheme. So our work with them had meant that they were able to improve their overall health and well-being, but then they were able to come straight back to us without the means of additional referrals when they came out of hospital to get direct support. Thank you.
So the key learnings, referrals had been quite slow coming through to start with. So what we did to enable a push on the referrals was the urgent community response team meetings, and the MDTs were attended to on several occasions to try and nudge people to remember that the service was there. A community connector role commenced, and that has been invaluable. Having that single point of contact for the teams, they work with the teams closely, they can chat through any cases that they've got. Weekly prompt calls set up with the UCR teams. Having champions set within the teams, again, makes communication a lot easier because the connector can meet with them, and also myself and Emma can go directly to the champions to identify any problems or any issues. And the really good news is that from this week, we've extended the KIT project to Reading. Next slide, please.
So in terms of outcomes, as you've seen, there was high positive response rate for people who were referred, but actually there was overwhelmingly positive feedback when people were leaving the pathway. So that kind of transferred throughout that whole process. We've saw an increase in direct referrals to Age UK, so we were building up on the awareness that the team had of voluntary sectors, but with quite good access to all sorts of things, it meant that single point made it more accessible for the teams and made them more aware of it. It also meant, and with the breadth, as we've shown you, of support that people were given, it identified there really was a need for these individuals for that onward refer and that continuity of an individual's pathway as they're moving through services. And finally, really, that it reduced the need for additional health and social care support, because what it meant was there was a safety net for people to be moved through onto. And often the people coming through were quite vulnerable and also had quite a range of complex issues. So it meant that teams were able to refer on, so that individual had continued support. And we do have some case studies to show you some of those individual circumstances.
Thank you. So I don't plan on talking through the case studies in any detail. It's just really, there's a number of case studies on here, and it's really just to show you that the level of help and support varied, obviously taking into account the individual's needs, but also the areas that they presented with and then were subsequently helped and supported with. But the whole aim of the project was to offer that holistic point of view and support for those individuals. So from very simple things through to helping with caring responsibilities, to practical help, to financial help, through to a whole variety of access to different services we were able to help and support with. And that's it. Thank you very much for your time. I do hope you find it interesting. My contact details are there on the screen should anybody have anything else to share or to ask. Thank you.
Thanks very much, Fiona, Kathy and Emma. I'm going to hand over to Katie just to explain this next bit. Katie.
Thanks, William. So with that case study, what we wanted to bring you was a really tangible example of the kind of collaborative work that we're looking to enable more of between the charity sector and health services. So we just want to now break you out into some small groups to have a quick discussion about why you think this partnership project was a success. And within your groups, if you could please nominate one person who will come back when we come back in 10 minutes time to write in the chat one word or a short phrase that reflects your discussion. So your answer to this question: what made this partnership project such a success? So I think Stephen is going to be breaking you out into small meeting rooms now. So just bear with us for a moment.
Just a small thing to add is that there's no wrong answers. We're just encouraging you